in Critical Care, the case-based series. Just before we begin, we do have a couple of reminders. We will be using the chat box for question and answer. To access this, click on the button at the bottom of your screen and feel free to introduce yourself if you would like to share a question throughout the session. If you have any technological issues, also send us a message through the chat and we would be pleased to assist you. And the session is being recorded and your attendance is consent to that. So thank you. Today we are at session 10 in our case-based series. Today's topic is obstetric considerations for oxygen therapy. The date is October 27th, and as usual, we are pleased to have the following educators and panelists, led by Professor Pauline Banguti and supported by Liberata, Dr. Honorine, Dr. Jackson, and Dr. Francois. So with that, I'll hand it over to Professor Banguti.
Thank you very much, Alana. And we appreciate your consistent support together with the assist team, the team from ECHO, and with the provided material from the learning resource course. It has been so helpful. As you all know, we are working in collaboration with the Stanford Anesthesia Division of Global Health and Dr. Anna Crawford, who is our senior leader. We are assisted by Assist International, and also the Project ECHO is managing the IT part, and we are all under this oxygen series. This is session number 10, where we are talking about obstetrics consideration for oxygen and critical care. Before entering next session, before entering the session, we want to raise up again the awareness about maternal health, obstetrics. Long ago, it has been said that the level of civilization of a society is judged by the care provided to the mother while giving birth. So if you want to know if your society is civilized or is being developed, you can just check on what is the level of care you provide to the mothers when they are giving birth, because no mother should die while giving birth. That's why we all fight to reduce the maternal mortality. You can see in Rwanda from 1992 to recently 2020, we've had a peak in 1995. You understand why? Where thousands mothers per 100,000 were dying. Today, with the DHS published recently, we are at 200. We are still at 200 mothers dying per 100,000 giving birth. So in Canada, they have 7. I think the lowest in the world. 7 mothers dying. We are still at 200 mothers dying per 100,000 birth. And the target for SDG, Sustainable Development Goals, is by 2030 to reduce by the quotas. Means we have to go below 70 mothers per 100,000 birth. So that is a huge work which can't be achieved only by the simple safe delivery and whatever. We have now to go up to the resuscitation, high level of resuscitation, because most of the mothers are killed by hemorrhage. And you know, when we come to hemorrhage, maternal hemorrhage, PPH, it requires a high level of critical care, resuscitation. Others are dying due to sepsis, septic shock, where we need intensive care, resuscitation. So we need to invest. The same for cardiovascular disease, the NCDs, which also are killing our mothers. So we need to have good perinatal care. The same for neonatal, we need to reduce the neonatal death. So that is laying the foundation for the importance of the course of today. It's about raising up our knowledge and skills, how to assist those mothers and see how we can save until we save the last one who is dying. And then we'll be a civilized society who is caring for the mothers giving birth. Next. So those are the objectives of today, practice change objectives. We need to understand the change of the physiological change during pregnancy. And for those who understand Kinyarwanda, it's said, when a mother is, igihe umugore atwite, ukuguru kumwe kuba kuri mumva, ukundi kuri ubuzima busanzwe. That means there is the high risk of mortality when the mother is pregnant. So we need to be closer and raise up awareness and good care to save that mother. We need to describe how physiological change of pregnancy affect maternal well-being, describe physiological changes, describe the change in the arterial blood gas, list the goals of oxygen therapy in pregnant women, recognize signs of maternal distress, recognize signs of fetal distress, list the multidisciplinary team member required for optimal care of the critically ill pregnant patient, describe the uniqueness of consideration during resuscitation of pregnant women, utilize cognitive aid for obstetric emergencies, be able to assess COVID protocol for obstetric patients. So at the end, we will check those objectives. If we really keep them, we understand them, and if that, we can change our practice. This session, next will be divided into 3 parts. The first part will be led by Liberata. The second part should be Xavier or myself, depending on the time and the availability. Third part will be led by Jackson. Then at the end, we'll wrap up and answer questions. So the floor is yours, Liberato. Liberato, the floor is yours.
I think she's yet to connect. We can still go ahead with it.
So as she's coming, we are having this pregnant woman, 28 years old pregnant woman with a gestational age of 29 weeks with fatigue and shortness of breath. Her symptoms started 2 days ago with a stuffy nose, rhinorrhea, and feeling of fever. Although she has not checked her own temperature, her pregnancy has been uncomplicated, but now she is concerned that she does not feel much fetal movement for the last day. She is a teacher. She is not aware of any exposure to COVID, but she does interact with children daily. So as obstetric history, 2 previous uncomplicated term deliveries. Past medical history, she has hypothyroidism, no past surgical history. She lives at home with her mother, her 2 children, and her husband. She takes levothyroxine, and she doesn't have any known allergy. So what do you think about this mother? Please feel free to share your answer. What will suggest if it was your mother, if it was maybe someone close to you in your hospital, how will you need as more element of assessment? What will be your diagnosis? And how will you manage this mother? So please, can you share your answers? Meanwhile, someone can help Liberata. She feels like muted. She's in, but muted. Any idea about the case? Audience? So next slide, please. So before we enter into the case, let us talk a little bit about some basics. Physiological changes of pregnancy. Please share, can you please share in the chat, what are the physiological changes you know for a pregnant woman? There is a big discussion about, does she become sick or is she normal? Is it a pregnancy normal or is it a patient who is becoming sick? So please, can we talk a little bit about the changes happening when you become pregnant? Please share your answers in the chat. Yeah, I can see Claudien is putting us some good source. The BP increases. What else is it? Do you agree? Physiological anemia. We need someone to share the most. Does the BP increases? The respiratory rate increases. Increase in oxygen demand. I'm still concerned about the blood pressure. Does it increase? Does it decrease? Increase in oxygen demand. Since there is problem respiratory, we should see the rate oxygen in blood. Metabolic demand increases. Yes. I'm still concerned about the blood pressure. Please, can you comment? Decrease of BP and increase of heart rate. Physiological behavior, physically. So does the BP increases or decreases? Does the BP increase or decrease? Psychological behavior, the BP decrease. So maybe the one who answered about increase of the BP was thinking about preeclampsia, which is another disease which can happen during pregnancy. But in normal condition, it trends to decrease a little bit. And we shall see as we are moving ahead. So next slide, please. So we have some cardiovascular changes. Liberata, are you able to follow or to intervene? So there is enlargement of chambers of the heart. We can't say it is a disease of dilatation of the left ventricle, which is mostly a disease, but it is just a little bit of left atrium, which is a little bit distended, and the left ventricle increases a little bit in size, which doesn't make her pathological, but it makes her just to be fragile, because she may have not enough pressures to pump in case of resistance in the systemic vascular resistance. Next. Next, please. So we have the blood volume.
Hello, Prof.
Yes, please, go ahead. Liberata, please go ahead. So I think she has some IT problems and the microphone is not functioning properly. So let us keep going. So we have the volume, which is increasing by 40%. So it means the plasmatic volume of a pregnant woman will increase by 40%. That's why you will see edema. We have expansion of plasmatic volume, allow for adequate perfusion of vital organs. total body water increases by 6.5 to 8.5 liter by the end of the gestation. You can see how this can cause anemic, dilutional anemia. So she doesn't lose blood, but she just have plasmatic volume, which is high without increase. There is a little bit of increase of red cells, but not enough to compensate. So she becomes a little bit anemic. The advantage is when she will bleed, when she loses 500 or 1 liter, she is losing a diluted blood. So the another change in serum parameters is plasma protein decreases, which led to decrease in albumin and decrease in oncotic pressure and lead to edema. Next. So we have some hemodynamic changes, which are decrease in blood pressure by 20% from the baseline. So she become borderline hypotensive, with a pressure of its lower limit, 90 millimeter of mercury over 50. So it is still, we consider it still normal for a pregnant woman. Due to the systemic vasodilation, we have, which is due to progesterone. So the heart rate will increase with a peak at 32 weeks. The stroke volume will increase and the cardiac output will increase with a peak at 32 weeks. So the low blood pressures is considered to be most amazing. So next. Respiratory system changes, starting from the upper airways. So you can have a little bit of edema. You can have edema, or the edema starting by the tongue, the oropharynx. There will be a little bit of edema, which will make the airway difficult to manage. The tidal volume will increase to 600, which is normally around 450 to 500. Minute volume increases. Decrease of functional residual capacity. So meaning the reserve will be very low. So she may desaturate very fast in case of induction of anesthesia or in case of apnea. Respiratory alkalosis, the renal system changes, mechanical obstruction due to the increase of intra-abdominal pressure, ureterocompression with a little bit of hydronephrosis and glucosuria. Next.
Professor Banguti, there's a question in the chat from Jean-Marcel. He wants to know if proteins are decreasing leading to edema, is it advisable to increase food and nutrition with proteins?
So the decrease in protein level is just physiological. That's why she needs to keep, it starts from the first trimester where there is nausea and vomiting, where she can't eat much. So she starts really not compensating, because now she should be sharing with the fetus. There are 2, but she's not eating enough to compensate. And when it reaches the fourth week, it reached the second trimester, it's already too late, but still she tried to eat, but not much of the protein. You will see her trying to be eating a little bit much, but not enough to compensate the proteinemia. And that's why she ended up being a little bit hypoproteinemic, and which will cause not only edema, but even the pharmacokinetic of the drugs will be constant. Don't know if I answered your question properly, or if you need more explanation. So we need to advise her to eat more proteinic food, nutrition, but she can't catch up to normalize it. It will keep a little bit lower until the end of the pregnancy. So we have other changes in the GI, which is compression of the stomach, gastric acidity and reflux, the risk of aspiration during induction, and endotracheal intubation. That's why we always prefer spinal anesthesia versus general. When we go to general anesthesia, it need to be rapid sequence induction because the risk of those pressure, intragastric pressure, is so high that she risks to vomit and aspirate. Next. So here are some questions and answers. Liberata, are you already back? The pregnant patients have an increase in the, so let us keep going, jump the question. Maybe we can give chance to Liberata to catch up at the end when if she managed to settle. So let us go next to the part 2, while maybe expecting Liberata to catch up to be with us. I will be happy that she participates. So
can I go ahead?
Let me finish the part 2 so that I will give to you the CTG.
Okay, great.
So I hope the part 1 was well understood. For some, if it is still it was new concepts, please feel free to put questions into the chat, and Liberata, you can always collect all the questions so that at the end of the part 2, before starting the CTG, I will break and start answering questions from part 1 before CTG. So please, Alana, you can keep the questions somewhere and then give them to me when I stop at the middle of part 2. So in part 2, we are discussing respiratory distress during pregnancy, including the fetus. So it means we will discuss mostly respiratory distress to the mother and the respiratory distress of the fetus. So at the end, for those who are involved in obstetric care, like midwife and nurses working in maternity and obstetricians who are here, there is a good session on CTG, which Jackson will take us through that. So for now, let us go through the respiratory distress. So the goal of this session, so the goals are to see what are the goals of oxygen therapy in pregnant women. When do we, up to when do we tolerate hypoxia, and when do we alarm about hypoxia in pregnant women? Signs of maternal distress, recognize and describe, and sign of fetal distress. Next. So you can, those are 2 questions, and please put the answers into the chat. Which of the following oxygen delivery devices can be used in pregnant patients? So feel free to choose your answer. Which one? Is it a venturi mask for the pregnant woman? You can use this tool and choose your answer. Please go ahead. Do we use venturi mask? Do we use mask with reservoir bag, non-rebreather? Do we use nasoprone? Do you use high flow nasocannula, or all the above? So some are using mask with reservoir, and we can see more people are using all the above. So let us say that you are all right, but all the above is the most likely correct answer. Because when you choose one and you exclude others, so it means we can't use, it seems like you are prescribing nasoprone or high flow nasocannula. So, but all those can be used depending on the level of hypoxia. So all the above, depending on the patient. So the second question, which one of the following is a reassuring sign of fetal well-being? Choose your answer, please. So I can see Xavier has joined us. Xavier has been busy with a good mission at the hospital of Kibagabaga. We appreciate your work at that hospital. I think you can take up the floor and continue for them.
Yeah, thank you. Thank you for inviting me now. I see all questions has been answered. And the second one is just to talk about the CTG as you introduced. Can you have next, please? Next slide.
Dr. Francois, do you want to go over the answer for this one?
Sorry?
This question.
The answer on this question. Okay, the answer on this question.
Can you comment the answers to this question?
The answers for the first question,
yes.
All oxygen devices here can be used. Has been answered this one.
Fourth question, Francois.
Wait.
We are not yet. We are not EG, so we are still at the beginning.
Yes, this one, the second question, which one of the following is a reassuring sign of fetal well-being? Actually, is a question coming from a CTG reason. So I wanted to see how our knowledge about the CTG interpretation while you're talking about fetal distress. The answer here we will see is the baseline fetal heart rate has to be in 110 to 160. This loss of baseline variability in fetal heart rate, we will see in the development of our course, that is not really reassuring for the fetal life. Next. So we have to know, as the previous talk, we talked about physiological change in the respiratory system, in other system also, but also our need in oxygen saturation in a pregnancy is different from the non-pregnant woman. So we have to take care about the oxygen saturation, which I have to emphasize on here. The time we are measuring oxygen saturation in a pregnant woman has to be the time of exertional. She has to work, and then at that exertional time, you measure the oxygen saturation with the target to meet SpO2 above 95% of oxygen saturation. Whether in a non-pregnant woman, above 92 is our target. Above 92% is our target in oxygen saturation. So we will have then the refractory hypoxemia when, despite all oxygenation measures, the oxygen saturation will be below the 95%, and that time we'll be talking about refractory hypoxemia. And when you have that case, please think about referral to advance the level where they may have other devices to improve the oxygen saturation of this pregnant woman. Next, please. Let us also talk about pregnant women in the COVID context. As you know, this time we are fighting this pandemic. When you have a COVID patient, on the top you have pregnancy, this time there is no experience someone can say. There is less developed protocols or guidance. But what we are telling you is that you have to consider the supplemental oxygen requirements that will maintain the target level of this pregnant woman. Put in hand that we will always need the saturation above 95%. And other thing you have to think about is the trend in oxygen demand and also the work of breathing. You remember the physiology change of pregnant women regarding respiratory system, they have to be, the respiratory rate has to be increased, but the target now in non-pregnant woman, you have to be less than 20, but in a pregnant woman, when you have respiratory rate above 30 breath per minute, please, that time you have to make sure you maintain the adequate level of oxygen saturation. Otherwise, you will the patient will worsen the situation, and you will have also a sign of being transferred to the higher level. So think about oxygen need, think about the work of breathing the patient is making, and then plan to refer the patient in a high level of support. Next. Refer to high level of support. Why? Because you may be using your own oxygen delivery devices as we described above, and you are not meeting your oxygen targets. This time, the next plan will be whether intubation or also using some non-invasive positive pressure ventilation, which are in the context of COVID are not really recommended at the time because of overspreading the virus. So the time the patient will need to be intubated is when we have to think about maternal status, the pre-existing comorbidities, presence of multiple organ failure, but also the required oxygen supplementation, which is over the what you are using. So you need to transport the patient. Please don't transfer patients without enough oxygen. Otherwise, from somewhere in any corner of the country to Nyarugenge, in the saturation less than 95%, it will be hard to me to save that pregnant woman. So we will need then the area intubation is better. Area intubation is better because as the time you delay, you have to know this the physiological change of the pregnant woman in airways with increased edema, risk of aspiration, and the limited functional residual capacity at the time she will arrive late, will not be able to prepare her for intubation. The time to intubate, it will be our time to lose her. So think about earlier need of intubation after your assessment of oxygen targets, your oxygen goal, your respiratory rates, and then think earlier as possible to the possibility of intubation and refer in earlier. So we will think to intubate a patient, a pregnant woman, to get the targets of saturation when we are using more than 15 liters per minute. I think in the corner where you are, you may have the 30 years old female who may need more than 15 liters per minute, and you still have less than 95. Please think about referring these patients. Or you are needing to use greater than 40 to 50 liters per minute using nasal cannula, which I think is not available in most of our settings. So please have a target oxygen saturation at the level we need. And if not, early transfer of the patient to the high care, it will be recommended. So I was talking about non-invasive pressure ventilation, which is not recommended in the COVID context, unless is the only way you have before you go to intubation. It's like a temporary measure. You may use it and you fail. Otherwise, intubation is also a good way to think about areas possible. Next, please. Next. Next. Can we have next slide, please?
Laws of the, I think there is a network issue with the Indian team.
Ah, okay, maybe.
Because I no longer see the screen, the shared screen
Yeah,
from Arana.
the same to me.
Yeah.
So as I introduced in the maternal distress or oxygen goal of saturation in a pregnant woman. So we are more talking about in the context also of the COVID, which is mainly attacking the respiratory system. The data shows that 75% of positive pregnant women are asymptomatic. So to my audience here, these cases who are asymptomatic are also challenging to decision-making of their treatment plan. Reason why monitoring of their saturation, oxygen saturation on the goal we talked above will help you to triage and know who to take to the hospital with the care, with appropriate care needed. 25% of others are symptomatic. Maybe this you may think symptomatic and is easy to screen them and transfer on the time. And of them, as the pregnancy is putting the patient to the risk of having severe disease compared to the non-pregnant and general population. So my experience today is not really good about the pregnant women who have been transferred with severity of their condition. Most of them are being admitted in ICU. Yes, some survived on a less average. They're ending up by being on a mechanical ventilator, and also, unfortunately, also maternal. Next. So this table here, that's to tell us the definition of the severity of the COVID on a pregnancy. I will not go all through this table, but important thing here is know whom we call asymptomatic, the 75 I said, mild COVID on pregnancy, of course, moderate, severe, and critical. So our patients who are asymptomatic take care of the monitoring of the oxygen saturation. They become mild if they start having this non-specific symptoms like fever, coughing, but without dyspnea. They will start being moderate illness when the saturation start to be less than 94. But here, remember, this is a case who is from general population where we said the target has to be above 92. So for this patient with pregnancy, we have also to show evidence of X-ray change. Most of people are fearing to do X-ray to the pregnant woman, but you have to wait risk and benefits and see what you can do to decide what to do. Also, there is a severe case when they start to be desaturating, a respiratory rate being above the normal condition. and then they will be severe when we will have the saturating the patient as what I define as refractory hypoxemia to the case you are having. So this below, they are the way to treat them. They are drugs with antiviral replication. They are also antiviral therapy you have to give. They are antibody therapy. This is in early case. Maybe you understand or you heard we are giving favipiravir, BAM, things like that. So you have to take care in early time and you manage this, the patients with pregnancy, as they may end up by being in a severe condition and we have bad result from recovering. Next, please. So these are danger signs which are associated either on COVID sign or obstetrical sign without. Let's go through some of them. They may be having difficulty in breathing or shortness of breath. Here you have to take care because a pregnant woman has respiratory changes by increasing respiratory rate. So make sure which element or features will tell you this is the shortness of breath or difficulty in breathing. Or they may be having also pain in the chest, but without the coughing. Take care also of them. They may have also, as the COVID patient is exposing people to have this microembolism, it may also have the P associated on that. And also they may be having altered mental status and severe sleeplessness. If you arrive on this level with the association of COVID, please, we are going in danger. So the monitoring of a patient with the COVID and the pregnancy has to be close. Close, considering also the obstetric signs like labor pain, rupture of membranes, vaginal bleeding, severe headache. All those things have to be took into consideration and think about the next management to best of care in early phases and early time when we are talking a pregnancy, a pregnant woman with the COVID or without COVID. Please, that is things we have to take care. Next, please. So we come up talking about maternal distress and also oxygen saturation target and goal and what to do in terms of management and early recognition of maternal distress. So allow me to go from maternal distress to fetal distress. There is a maternal distress which also will lead to fetal distress, or it may be having causes of fetal without maternal, but how will you know fetal distress that is reassuring or not reassuring while you are not having the kid, the fetus out of the mother's home? So that we have to think how to monitor them. The baby is not receiving enough oxygen through the placenta from the mother. This time, the fetal distress of the fetus may be due to inadequate oxygenation. So we have two ways: oxygen from the mother, and when the mother doesn't have enough oxygen, you understand we are going to lose the two people, a mother and the fetus. Also, maybe that time we need the fetus to breathing in amniotic fluid containing the meconium. This will be characterized in fetal movement change. The mother will telling you I don't hear the fetal movement, or they are decrease of fetal movement. If it persists, there is problem of growth retardation. Also, the heart rate may change. To know the change of heart rate and the fetal health, we have to do what we call CTG, cardiotocography, to monitor fetal heart rates and also to monitor the uterine contractions when they are there. The CTG we are going to use to know the maternal hypoxia or respiratory distress, we use oximeter, pulse oximeter, to know if we are having a target of our oxygen saturation above 95%, as we emphasizing on. For the fetus, the CTG is now our tool to know the fetal cardiac response to the decline of oxygen. And also will show us that if there is deceleration, which we understand further, on the CTG, we have to think on danger to the fetus, and then we have to think what to do in that early time. And there is acceptable time also to deliver the kid, the fetus, when the mother also still in danger. Next, please. The CTG is for obstetricians, midwives, but as we nurses, doctors, or whoever is in this session, we are working some of us are working in remote areas. We may be using this CTG and having some at least principles of interpretation and monitoring to look on it and think is normal or abnormal. That is the goal for now. We are not going to go in deep interpretation of the CTG because there is some complex in it, but to our level of understanding, whether we are in a health center, health post, or in a hospital, please, the way to monitor fetal distress is having a CTG. Have a CTG and look whether normal or abnormal. That is what we will have like goal for now without being in deeper interpretation. So the principle of CTG monitoring, that is, we'll have as if you have a combination of several abnormalities, we'll increase several abnormalities on the CTG, we'll increase the likelihood of fetal distress, where I'm saying that the goal is now to know normal CTG, abnormal CTG, and think of some differentials we may think on. We are having 4 things. On the CTG, we have 4 things to understand. We have the baseline fetal heart rate, which is the fetal heart rate had to be in 110 to 160. Below that is not good. Above the normal range also is not good. After that baseline fetal heart rate, we have to think about the baseline variability. So if your CTG doesn't show variability, that means you are not in a good way your fetus is in danger of showing fetal distress. The other thing is acceleration. If your CTG is not showing acceleration, they are absent or they are reduced. Also, we have to think of a kind of fetal attack or fetal distress or fetus being in danger. When there is this deceleration, now at this time, you have to call a doctor to deliver the kid because it's going to lose the fetus on this level. So as we said, the CTG is showing 2 things, monitoring fetal heart rate, the cardiac change on that oxygen needs, and also the uterine contractility. When we are looking on that CTG, there are those 2 things. And when there is a contraction, there may be some change in heart rate of the fetus. You have to say it's normal or abnormal, in which reason. Next, please. As I said, here expressed, we are having the baseline fetal heart rate on your CTG. If you are having the bradycardia less than 110, you may think in a cause like the compression or acute fetal hypoxia. At this time, you have to give oxygen regardless of the oxygen the mother is displaying. The mother may be having 99%, but you are reading a decreased baseline fetal heart rate, give oxygen. Or this may be caused by the postpartum or congenital heart abnormalities. So think about what can cause the bradycardia of the fetal baseline from your CTG, as we said in previous. The tachycardia will be due to excessive fetal movement, uterine stimulation, mother's stress or anxiety, also fetal infection, chronic hypoxia, or prematurity. Think on the two sides. In postpartum, you are likely to have bradycardia. In prematurity, you are likely to have two tachycardia. So these are the possible differentials I need you from this to think about when you are having those changes in the change of baseline fetal heart rate. So having in mind 110 to 160 is where our CTG have to play in between that range. Next, please. So there is also fetal variability. Fetal variability means we are saying you have the baseline heart rate, fetal heart rate, and a 130, and then we are expecting to have fetal heart rate variability like 145 or 125, because you need this variability in between the normal beauty to be change in the is normal when the values between 5 to 15, is abnormal when it increases above 15 from the baseline used to display on your CTG. If there is a decrease in variability, the fetal may be sleeping or maybe premature, also maybe receiving some opioids. Like when we are having a patient who is pregnant, is on the mechanical ventilator, we are using this opioid, we are expecting that to have this decreased variability. Other things are signal of fetal hypoxia if the variability is decreased, absent, or is increased in abnormal way. Next, please. Let's talk about acceleration. Acceleration is a sign of a healthy fetus. That is a message when we say acceleration on CTG, a sign of a healthy fetus. This means if you look on the CTG we are having here, the image, on the bottom, there is a contractions. With the contraction, you will have in between one contraction. We should have two contractions into 10 minutes. You will see on the top, there is some movement, but the variation is in between 120 to 150, 145, 145, something around. These are normal variation and a good sign of fetal viability and the fetus who is healthy. And it has to be increased more than 15 for enough seconds. That means the fetus activity is normal. So on this CTG, look on the two, on the bottom and on the top. The top is for fetal heart rate monitoring, whether the bottom is the uterine contraction. Uterine contraction goes together with the fetal heart rate change. This acceleration is a good sign for the fetus health. Next, please. When we have deceleration is associated with uterine contraction, but not all deceleration. When we have not all deceleration are having poor outcome, but in general, deceleration is not a good sign. So what we are seeing as deceleration, we have 4 types. We have earlier. The early deceleration will be due to the compression of the fetal head during the contraction. There is a contraction, and also the head will will compress the fetus at the time we'll be calling it early deceleration. So when you find early deceleration, you will be needing to position a change of the mother and things will be corrected. We have late deceleration. We have variable deceleration, and also we have prolonged deceleration, which are pathological and abnormal and very fatal to the fetus, which I need to have a look next, please, on them. Late deceleration, looking on it, we see is uniform in shape on the CTG. If you remember the normal CTG, we shouldn't see these things like in emergency medicine, we have what we call the wide QRS on ECG. Things we are having here is like that. They are not regular shape, they are not things. This is coming after the peak of uterine contraction. On the bottom, we are having, let's say, take the first, the second contraction. After the second contraction, you go on the top, you will see there is a deceleration even into the 60 beats per minute. This really is very, very bad. And we'll show you that such case of CTG, please, is a sign of hypoxia, placenta abrasion, cord decompression, or prolapse. So think about possible differentials when you have such CTG image. Next, please. Compared to that one, to the late deceleration, we saw it, which comes after the uterine contraction, you will see this variable deceleration can come anytime. And we are having together on the bottom, the uterine contraction, and above the same time, we are having the variation below 110. And between those two variations, we are having other many increased variability of the fetal heart rate. In such case, you might say the compression of the umbilical cord, which also is leading to severe fetal hypoxia and is a bad sign. And to this, think about severity to the fetus. Next, please. Next is the prolonged. With this prolonged one, again, there is reduction in fetal heart rate more than 50 beats per minute. When you see on this CTG, you are seeing the orientation of the CTG is showing down. It's showing down with the same variability into the fetal heart rate. Don't see on the bottom is a kind of the contraction. So to this time, you have to say there is a decrease in oxygen transfer because of maternal hypotension, uterine hypertonia. There is too much contraction of the uterine, and this fetus is exposed to death, the severe hypoxia. So from this, CTG is not easy. Next, please, to the level where we are, having it in the hospital, in health facility, will help us to know normal and abnormal. From that, we have take message here is making sure your CTG is reassuring, is abnormal, or is non-reassuring. There is this important things. Baseline rate being in normal range is non-reassuring when it's meeting such element as we discussed. There is acceleration, if yes, is reassuring. There is deceleration, we have to have no. As I said, deceleration is a sign of poor oxygen transfer to the fetus through the placenta. To you are normal fetal heart rate, you are having variability 5 to 15, you are having acceleration of the fetal heart rate, you don't have deceleration, your CTG is normal. Your CTG will be abnormal when you are in abnormal limit of our normal fetal heart rate, baseline heart rate. And also the variability is more than the limit, 5 to 15, as we said. And also as acceleration to this here, they are or they are not. It's up to you to put a comment, and then we'll help you to decide. Also, deceleration, a typical variable, as we said, late, prolonged. So all those things, we consider them, and you say your pathological CTG versus normal CTG. When you have suspicious CTG where we are working in health facility or where, please, as healthcare providers, while caring a pregnant woman, I think the last message from my talk is this table. We have to understand what is mean and then try to apply it. From now, I think we can implement a strategy at the health facility where we are, and knowing reassuring, non-reassuring, and abnormality by consideration of the 4 elements we have to consider on the CTG. I think, thank you for your audience. Let me pass the board to the next presenter, because as we are talking about hypoxia, we may be needing to do no resuscitation if there is no question about what I am saying. Thank you.
Thank you, Xavier. And thanks to the audience for having me. We are now heading to maternal and neonatal resuscitation, as
Jackson,
Dr. Xavier said. Yes.
Jackson, can you give a few minutes to the audience to see if there is any pending question in the audience? Alana, did you check the chat and see if there is a question?
There was one question, actually. Edward was wondering, is it allowable to perform CPR for a pregnant mother in the 3rd trimester? And if so, how?
So Xavier, can you go ahead about CPR for pregnant women?
Okay, thank you for the good question. CPR for the pregnant woman have to consider the viability of the fetus. Internationally, the standard are talking about 24 weeks of pregnancy, but locally, I don't think 24 weeks of pregnancy may survive. For us, doing a CPR on the pregnant woman, you consider the pregnancy weeks, 28, okay, by standard 24, but we say that you do what we call emergency C-section during CPR. When you do CPR 4 minutes without rescue, you do CPR, but the mother is not recovering. At that time, you do a C-section, which we call emergency section, in less than 4 minutes. Also, is a quick, and also so you have like a 10 minutes CPR of the mother and also delivery of the baby. We are allowed to do CPR on the mother, considering also those consideration of C-section during CPR. I don't know if I'm clear on the answer. Edward, do you understand?
Xavier, as you said, we consider gestational age and we consider viability of the fetus. If the fetus is no longer viable, and then that time you will need to just tilt the fetus manually, and then put the heart table on the back of your patient and keep going with your CPR. But if the fetus is viable, you will need to do CPR, but within 4 minutes, deliver the baby, the fetus as quick as possible. But when it is below 24 weeks internationally, you won't just have outcome out of the fetus. Locally in our country, we have studies which are now going up to 28 weeks with our neonatologists. So I think this can be an information to have with our audience.
So as they are saying, we have to consider 2 in 1. So we have 2 patients in that one mother with preeminence to the mother. Mother first, not baby first, mother first, because the mother can always give birth to another baby. So check if the mother, so it's the mother who gets cardiac arrest, check if the baby, the fetus is alive. If the baby is still alive, so you need to save both quickly. CPR for the mother, which you know, when the mother is alive, she will perfuse the baby and keep the baby alive. Don't rush to C-section without trying a CPR to resuscitate the mother. She's our main patient. So if after 4 minutes, the mother doesn't come back to life, then we can go to C-section. Going to C-section, we know we've sacrificed the mother. We are saving now the baby. If we can save both, it's good. But if we've lost our main patient, who's the mother, then quickly remove the baby. At least we don't lose both. So 2 in 1 with preeminence to the mother. The baby after, but don't lose both. Either you save both, or if the mother is lost, then save the baby. So it must be a very quick thinking and quick skills to remove the baby when we realize that the mother is gone. So maybe Jackson, we give the floor to Jackson.
So this, as the audience has introduced on this third part, that echoed on resuscitation of the mom and the neonates, and now we are going to see who are making the team, the multidisciplinary team that are there required optimal care for a critical ill patient. We shall describe the unique consideration for resuscitation of a pregnant woman, and then see the role of cognitive aids in the case of obstetric emergence. And then at the end, we shall see some COVID protocol for obstetric patients. Next. So in any situation where you be seeing at emergency, you've got teams that are there to resuscitate a patient, but in a pregnant woman, you have optimal number of members that make a multidisciplinary team of optimal care for critical ill pregnant lady. We have someone who is alerting that we have an in danger patient, an in danger pregnant woman. And this one is called a narrator. That's a narrator or non-clinical supporter who is there, any attendant to the woman, any next of kin, or the woman herself can just be classified the first person to alert the patient has a problem. And then we have someone who is there to record that this pregnant woman has gotten a problem. It's the recorder. That may be our support worker, healthcare assistant, or a midwife who is just around, who will be there and just to record that the patient has got. This one will just have to take some vital signs, just very initial vital signs. And then the recognizer, who is a midwife, the recovery, or any nurse working within the unit, or foundation doctor, who is there now to interpret vital signs that were recorded by the recorder. And then this one is a recognizer. The fourth person who makes the team is the primary responder. This one is a junior doctor or specialist trainee or a foundation doctor or a residency with appropriate competencies, who is there just to now alter some endangered vital signs that the patient has or the pregnant lady has. If this is tachycardia or blood pressure which is high or low, and a hemorrhage, and then this doctor or specialist trainee or foundation doctor will be there just to give basic support or emergency support. And then the secondary responder will be an obstetric or anesthetic specialist trainee. Here comes residents in anesthesia or obstetrics. They have advanced level of understanding to this matter, and then they can just be responding to not a higher level of management. Now you have a tertiary respondent who are consultants in anesthesia and in obstetrics. These people will be there just to respond and then give definitive management to the just emergent or critical ill patients that we have with in considering the mom and the fetus. Next slide. The next slide shows the sequence that you have in case you need to intervene. So as you can see, the non-clinical supporter may alert the people, and then the very basic person will record vital signs, alert people who can now interpret the vital signs or endangering deranged physiology of which is not normal physiology of pregnancy. And then you go to the primary responder who can just go for any emergency, and then you report to someone who has any advanced level of knowledge, and then to tertiary who will come at the end with definitive management. Next slide. So the unique consideration that you need when you're doing resuscitation of a pregnant woman, remember that there is physiological changes of pregnancy which will be endangering our hemodynamics, our respiratory system, our just hematology things. So in doing so, the very best thing that you need to remember is the autocover compression. From 20 weeks of gestation, you need to tilt your patients into left lateral so that you allow venous return to the heart of your mom. Then remember that these changes in lung function due to the upward displacement of the diaphragm, and then the risk of hypoxia, difficult intubation in case you are going to intubate during your resuscitation. And then this patient is at risk of aspiration because they have full stomach due to hormones and then anatomical changes due to enlarging womb. And then remember, as we talked during CPR, beyond 4 minutes and gestational age beyond 20 weeks with, this is the ACOG recommendation, and the international 24 weeks. In Rwanda, they go to 28 weeks. You may need to remove the baby in case our mom doesn't respond quickly to our resuscitation. Next slide, please. Then here comes what we always forget in case we have very emergent things. It's a very disorganized situation. You have stress. You need to save both the patients. You need to save the mom, both the fetus. In this situation, you need something that's a systematic approach that may help you to achieve a certain goal in an organized way, avoiding chaos, and then having everyone assigned with roles, defined, clear message, and then having the same goal. You need a team. So in this way, you need what we call cognitive aids. These are printed papers which are always hung on walls. You may have just some of the notebooks with cognitive aids. You may have all these checklists with you, and then they improve the performance of individuals and team that reduce errors, omissions, and timekeeping. And at the end of the day, you shall achieve the same goal. which is saving the mom and the baby, of course. And then non-technical skills are needed. When you're using cognitive aids, sometimes you need communication skills, you need awareness of the situation that you have. You need how to transfer your message to the colleagues, to the team members, and then the way they communicate, so they give you feedback to you then. And then at the end of the day, these cognitive aids may help you to overcome hierarchical barriers and then get the teamwork. You don't need to just go, professor will need to do this. No, the obstetrician will be the one to do this. But at this time, resuscitation is your main goal. You need your pregnant ready, both the pregnant ready and the fetus to be saved. And then again, you need team working spirit. Then remember to consider social cultural norms in case, because there are some of the norms that we have in our culture which are different from Muslim culture, which are different from country to country. We will be considered in this case when using the cognitive aids, because are very important in this matter. Next slide. Great. How now will we assess COVID protocol for obstetric patients? Of course, there are measures we need in case of non-pregnant patients. And then at this level, we need some measures or protocol for a pregnant lady. Dr. Xavier echoed about the symptoms and severity of COVID symptoms, signs and symptoms. Now, in pregnant ladies, are they the same? I think the same, but there are some added values to a pregnant lady. Symptomatic pregnant women with COVID-19, they are very risky of more severe illness due to their deranged physiology, due to their changes, physiological changes. Then their heart is very heavy. They are at risk of having cardiac failure. So this is 2 patients in 1. So you need to consider that. There is increased risk of ICU admission, need for mechanical ventilation, ventilator support. And a colleague from US called about the need of ECMO, because you need to just ventilate or oxygenate the 2 patients, 2 people in 1. And then there is high risk of death. There is another consideration that you need to take into consideration, temporary separation from the neonate in an effort to reduce the risk of virus transmission, except if the neonate tests positive. This is a breastfeeding women. You need just to separate the mom from the breastfeeding mom, or in case that's in case you still have obstetric consideration up to 6 weeks postpartum, you still consider this is a pregnant lady. It's postpartum 6 weeks is still considered as a pregnant lady, because you still have physiological changes of pregnancy still there. So you may disconnect or separate the neonate from mom. And then if the neonate tests positive, if the mom has 10 days passed since their symptoms best, if the baby has no fever within 24 hours, so breast milk expression with a manual electric breast pump may be used, or preventive measures ought to be observed, as I said. Remember, when from moderate to severe or severely critical ill pregnant lady, you need to refer the patient to where they can handle, they can have materials for invasive airway management, where they have enough of oxygen and different oxygen provision devices. Next slide. So this is the part that we need from our participants. Maybe Arana can help us to use a poll. Which of the following does not take part in the management of a critically ill pregnant woman? Arana, can you help us just put up code? And then we hear from the participants. Or even we can use the chat. Thanks. So participants, you can use this poll, and then we see the best answer among these. Which of the following does not take part into the multidisciplinary team when resuscitating a critically ill pregnant woman? That's good. A narrator, quaternary responder, recorder. Okay. Narrator. Okay. Primary responder, quaternary responder. One more minute for the responder. From the chat, some of the people said B might be the answer. You can see the quaternary responder may not be involved in managing a very critically ill pregnant woman. So the best answer would be quaternary responder. And then we can end the poll. Okay. So as we discussed, remember, we have someone who will be alerting people that we have a critical ill patient. We have the recorder, recognizer, primary, secondary, and tertiary responder who will be involved in management of the case. Thank you. Next slide, please. So the following is not involved in assessment of a critically ill pregnant lady. Now we can go for a poll on this one. Alana, can you help us with this one again, with the poll? Great, thank you. So from the audience, which approach in the following is not involved in the assessment and management of a critically ill pregnant woman? ABCD approach. Some said system by system approach. There are two responding the second option. One said D would be the answer, BRS for pregnant women. Two more seconds, and then C. So as you can see, a very critical patient as well as very pregnant now, you need to assess, detect something, and then treat, which means D is the answer. BLS. BLS involves the system that you will need to assess airway and act, breathing and act, cardiovascular and act. That's the way. But system by system won't allow you to go and act, okay? Which means the answer B is not correct. It's not involved in assessing a very critical pregnant lady. I think the floor is up to Professor. Thank you very much. Any question will be addressed through the chat. Thanks.
Can we come back to the objectives, the yellow or orange slides, the third slide from the beginning? Alana? Yeah. Okay. So to summarize, we need to come back to this one because that's where we are targeting to respond to those practice change objectives. And we remind you again, you can find all those materials on the LRC, and you will find this. The link is in on the platform of on the WhatsApp platform, so you can find all the recorded session and the material. So we've tried to list the physiological changes. In the first part, we discussed about physiological changes from the head to the toes, or from A, B, C, D. We can see in the airways changes, which makes the airways management difficult. So edema, we have short neck, we have the breasts, which are quite large and can obstruct the laryngoscopy. We have quite a number of changes, which makes the intubation quite difficult, and even the normal airway management, or even the voice can change. Even the trend to bleed into the mouth, to the nose, because of the enlargement of the vessels. We've talked about the breathing can be a problem because the tidal volume increases, the minute ventilation increases, but the FRC decreases, which decrease the reserve, the capacity, the FRC, the functional residual capacity of the pregnant woman is decreased, meaning in case of apnea or dyspnea, she doesn't have enough reserve to protect herself and to protect the baby. She desaturates very quickly, and she's a difficult airway management. So easily you can lose her. Studies have shown that general anesthesia is 16 times dangerous than spinal anesthesia because of difficult airway, not only for intubation, even for ventilations. It's quite difficult. C, circulation. The cardiovascular changes, we've seen them. The chambers are quite a little bit enlarged and a little bit weak, not strong enough against resistance. We have some vascular changes. The elasticity has changed, reduced. That's where the blood pressure drops. The parasympathetic volume is increased 45%, 40% of the increase in the fluid, but without increasing red cells. So we have dilational anemia. So all those changes, neurological changes and drugs, there is drug effects. The onset is very fast than for the normal patient, very quick. So careful with the dose of the drugs. So endocrinological, there is quite glycosuria and tendency to hyperglycemia or sometimes hypoglycemia. The clotting factors have changed, so risk of bleeding and even DVT. So there is a lot of changes which would push the patient at risk of complications. About the goals for oxygenation, we've seen that an SpO2 less than 95 should raise our awareness and start assisting the baby, because we are considering 2 in 1 and we need to give them enough oxygen for 2. So we can use all the equipment. We can use nasoprom, we can use normal mask with reservoir, Venturi mask, non-rebreather mask, up to the NIV, even though it is quite controversial. And if any discussion for intubation, need to do it very fast and quickly and on time, because the risk for the saturation is quite high and losing the airways, so, and the risk of death. So we've discussed signs of distress for the mother and for the baby. And we've discussed the CTG. We take like 20% of our time teaching went to the CTG discussion, hoping it helps some midwife and nurses in some hospitals. If need for some more discussion, please feel free to join us on WhatsApp. We've gone through consideration for resuscitation and critical care and how to use a systematic approach towards saving pregnant women's life and baby's life. So if any other question, please feel free to share it in the chat before we close the session. We remind you again, the life of mothers counts. You can even say count twice than others. Even oral life counts, but the pregnant woman should not die while giving birth. So we need all to invest in protecting our mothers and our babies. Any question? So I see there is no question up to now. You know, you have our WhatsApp group. You can always join us. You know how to contact us. And please feel free to send your questions, and we will try our best to give you answers or to consider it in the next discussion. Alana, the floor is yours.
All right. Thank you very much, Prof. Banguti, for your time. Thank you for this very enlightening session, and we really enjoyed the session. Thank you to all the panelists and all the participants. Like Prof has already said, kindly feel free to join our WhatsApp community, and then the link to the resource center has been shared on the chat. Please, you feel free to peruse the link at your own disposal. Looking forward to you joining us in our next session, which comes up on November 24th. The next session is the 11th session, and our topic will be essential emergency and critical care. If you have questions, please send us an email at echo@assistinternational.org, echo@assistinternational.org. Thank you so much and enjoy the rest of your week. Bye for now.
Oj, please, Oj, can you present yourself? Because,
yes,
we are
Prof.
used to Alana, and we can hear a new voice.
Yes, we've been discussing via mail, but we haven't met over the call.
Okay.
Yeah.
So you are a new assistant for our sessions, so people will be happy to know about you.
Yes, I'm Oge, and then I work with Assist International. I responded to a few of your mails, especially as regards the quiz and all of that.
Thank you very much. So thank you very much, and it was a pleasure. Bye-bye.
Bye for now.